Welcome to the Ortho Carolina live webinar series. Today, we'll be hosting a series of innovative treatments on knee arthritis. And this will be live streamed on Facebook, LinkedIn, and YouTube. I am Dr. Brad Ellison, Ortho Carolina hip and knee specialist. I've been in practice for nearly 15 years, working on areas of knee and hip surgery. I'd like to share with you some of our treatment considerations for knee arthritis today. So we'll go through a brief presentation and feel free to address comments or questions that anyone may have, and we'll collect those along the way and try to answer those as we kind of get through the end of the presentation. So thank you for joining us today, and feel free to reference this in the future with your friends or family that may have some questions or concerns about knee arthritis. So again, we'll get started today. So thank you for joining us. First, I think it's good to kind of understand what knee arthritis is. We had a similar series a few months ago, kind of going over some of the description of what knee arthritis is and some of the non-operative treatments for that. And we'll briefly restate some of that today just to give context for the problem that we're talking about. And so knee arthritis, quite simply, is a structural disease where the cartilage wears away over the knee joint. And you can see those erosions there on that picture where that smooth, shiny white surface of cartilage gets worn away, and there's potholes that develop structurally, these defects inside the knee joint that cause pain and swelling and stiffness. And this is a chronic, progressive degenerative disease that worsens over time. And so once you have this condition, it can represent it as a mild condition and progressively worsens to more moderate disease, then to more severe disease over time. So in terms of who gets knee arthritis, it's commonly concerned with more of our older patients and population, and colloquially referred to as boomeritis. And that's because the prevalence of arthritis increases as we get older. And as we enter the sixth decade of life, it impacts nearly 10% of the population. Then as we get to nearly 75 years of age, almost half of the population of U.S. citizens may be impacted by knee arthritis. This is translated in the country to about 500,000 knee replacements every year. This is projected to go up in year over year, and by 2030 to have nearly 3.5 million knee replacements performed in the United States. So today's patient that presents with knee arthritis are now more active than they ever have been before, with longer life expectancies. They're better educated with internet and information more readily available. They're more than likely to be female. And unfortunately, there's also more predilection for obesity and to be overweight at times. This can have some impact on treatment considerations, both non-operative and operative for knee arthritis. We'll always start off with different types of supportive activities that can be beneficial for patients with knee arthritis. And that'll be in the form of exercise or physical therapy that will focus on low impact, elliptical, strengthening, and stretching exercises. This can be in the form of using a cycle or treadmill, yoga, tai chi, swimming, or water aerobics, all have proven to be helpful for knee arthritis. At some point, the pain can be more debilitating and cause a loss of balance or stability, and a cane or walker could be helpful or supportive. Other treatments like knee sleeves and massage, dry needling, or even ultrasounds or some cold lasers have been recommended and shown to have some improvements for some patients in certain cases. Patients are always asking, what else can I do to help minimize the dysfunction or problem with knee arthritis? I think some of the things that we probably underestimate is the type of food that we take in, such as an anti-inflammatory diet. And it's been shown that if we can direct more of our intake to high omega-3 type foods, which include fish oils and salmons and leafy vegetables, and limit the low omega-6 types of foods, which typically are in polyunsaturated fats or grain-fed animals, might go a long way to help reduce the fuel that is internalized in our body that can make the knee arthritis rev a little hotter, become more uncomfortable with the inflammation that's associated with it. Also, working on keeping our body weight down to an ideal level will be important, and that will reduce the amount of weight or force that goes across our hips and knees that can be impacted by arthritis. And a well-coordinated diet can be helpful in achieving that. Different medications and supplements are commonly recommended for knee arthritis. It's estimated that the average American will spend over $3,000 on different medications and supplements for knee arthritis in their lifetime. That can come in the form of over-the-counter treatments like glucosamine and chondroitin. About 1,500 milligrams of glucosamine and 1,200 milligrams of chondroitin are recommended and have shown to have some improvements in milder levels of arthritis. Topical NSAIDs, such as over-the-counter treatments like Voltaren, which is readily available and does not require a prescription, can also be helpful in mild to moderate arthritis and providing some symptomatic relief. Oral medications that are readily available and over-the-counter, such as ibuprofen and naproxen, are commonly used to treat arthritis and can be helpful in knee arthritis as well. Prescription medicines such as COX-2 inhibitors or cyclooxygenase 2 inhibitors like Celebrex can be beneficial and perhaps more selective in targeting the inflammation of the knee arthritis, and therefore perhaps maybe a little more gentle on the stomach and other kind of GI discomfort. There are associated risks with renal and cardiac function, so working with your doctors to ensure that the medicine chosen to help manage your arthritis is appropriate will be important. Knee injections are commonly offered for knee arthritis, and the most common type of injection is a steroid or cortisone injection. And this can be shown as the picture shown here, where a needle will infiltrate the knee. Really about 2 or 3 seconds is all that's needed to get that medicine introduced inside the knee joint. It'll feel like a bee sting. The hope is that it'll provide at least 1 to 3 months of relief, and this can be less effective as knee arthritis becomes more advanced or severe. Another type of injection, like hyaluronic acid, or commonly known as HA, can be offered. There's many different FDA-approved formulations that are available in either a single or a series of shots, and that can also be designed to impact a patient with arthritis by providing 1 to 3 months of relief. And there are some good scientific studies that demonstrate that these are more effective than placebo alone. Another injection that's gaining more attention is platelet-rich proteins, or PRP. And this is where a blood specimen is taken from a patient and concentrated to get really the 3 times the normal platelets in peripheral blood with associated growth factors. And this is shown to have some improvements in knee pain and swelling associated with knee arthritis for up to 3 to 6 months. Sometimes this can be a little bit difficult to obtain due to the lack of universal coverage by insurance companies. Knee joint replacement is ultimately where the definitive surgery is considered to address knee arthritis that's failed other conservative treatment options. And we know that over 5,000 Americans will undergo knee replacement surgery this year, and more of those to come in the future. It's considered to be one of the most successful surgical advances in the history of medicine. Most patients need to clearly understand what are their expectations after knee surgery and knee replacement specifically. So they can get to regular activities such as golf and tennis and dancing, hiking, regular exercises with treadmill and elliptical activities, gardening, fishing, traveling, and most importantly, being with their family and their grandkids is a common request to see if they can get back to those type of activities. Usually after knee replacement, it's recommended to avoid the repetitive impact, heavy cutting and kicking type activities that you might see with football, soccer, martial arts, or distance running. There's several different types of knee replacements. They're usually put into 2 categories of a partial knee replacement and a total knee replacement. You can see here with this illustration where the one on our left shows a partial knee replacement where the inside of the knee has been replaced, and the one on the right shows a more comprehensive or total knee replacement where the inside and the outside have both been replaced. This can further be broken down into understanding the different types of compartments in the knee, and they're quite simply, there are 3 compartments in the knee. There's the inside, which you can see here, and then there's the outside shown here, and there's a kneecap as well. And partial knee replacements come in the versions of either a single compartment or 2 of the 3 compartments being replaced. However, if the arthritis is more advanced and involving the majority of the knee joint, then a total knee replacement is recommended, which will comprehensively address the entire knee joint and resurface all of the involved and arthritic diseased surfaces. Sometimes if a partial or a total knee replacement were to fail or need to be revised, a revision knee replacement may be undertaken to correct that problem, to provide an improvement in their condition. We'll provide a quick overview of knee replacement where the simple goal is to relieve pain, maintain an active lifestyle, and enhance the quality of life of the patient undergoing the procedure. It takes about 1 to 2 hours to perform the procedure. Anesthesia is designed to control the pain with different types of approaches, including nerve blocks, sedation, and medication. The patients will get up immediately after surgery and walk and participate in a knee therapy program. Many patients are shifting to having their surgery done in an outpatient setting, which is beneficial for a lot of reasons, or they may opt to stay in the hospital for a night or two. Usually, medications will be taken after surgery to help reduce the risk for blood clots. And patients can anticipate the first 2 to 3 weeks hanging close to their home and being comfortable and resting in their home, protecting that incision, being sure they're not overdoing it or engaging in excessive activities that can result in more swelling or drainage around the incision. So those first 2 to 3 weeks are where you're a bit more protective and taking it easy at home. After that, the incision has usually healed sufficiently to get you out of the home a little bit more, where you can start resuming driving and short shopping trips and limited out-of-home activities. And by 6 to 8 weeks, most patients are ready to consider returning to work, travel, or other regular activities. We'll go over some of the latest technology and improvements in knee replacement surgery that I think have really advanced this field over the past decade and allowed us to shift many of these surgical cases to the outpatient setting. The technology has further enhanced the surgical treatment of this condition and patient outcomes as well. The first is improving and optimizing the anesthesia, which goes a long way to help patients be more comfortable. And this has really helped transition patients to a successful outpatient knee replacement experience that has led to further improvements in cost and satisfaction and outcomes for those particular patients. Improvements in incisional healing and cosmetic scar are really a benefit for the patients, as they like to kind of heal up more quickly without any concerns for wound healing problems. And when they're sufficiently healed up, they like to have a very minimal scar that's apparent. And some of the improvements in that aspect of the surgical care has gone a long way to achieve that for the patients. We have improved and enhanced therapy programs, which really accelerated the recovery for patients undergoing knee replacement surgery. And we'll show some details on that. And some of the really interesting innovation and technology with computer-assisted surgery and patient-specific and custom instruments and implants, as well as robotic-assisted techniques, have really gone a long way to help bring the technology into the operating room to help facilitate surgical treatment. And kind of the next step is where this technology will be going in the future will be the use of augmented reality and artificial intelligence to help with surgical technique. So first, the anesthesia and pain management improvements have really been quite dramatic. And this is through the lens of using a general or a spinal anesthesia in combination with regional nerve blocks or intraoperative anesthetic medication. And this has led to a really successful outpatient knee replacement experience for many patients, where they have reduced need for narcotic medicines, which leads to reduced incidence of nausea and constipation. They're able to get up and move more quickly and reduces the concern for adverse events. Further, this has led to improvements in postoperative pain scores and satisfaction, and quite importantly to the healthcare system overall, dramatically reduce the cost of the knee replacement experience and really can enhance the outcome for the patients. So in terms of the incision, sometimes this can be an overlooked aspect of the surgical care, but is immensely important in the overall complete healing of a patient undergoing knee replacement. And different techniques have evolved through the years, and certain strategies are now designed to kind of help bring the skin edges intimately close to each other so they are sealed, so there's no effective drainage. This goes a long way to help reduce infection. Certain bandages go a long way to provide some silver impregnation over the incision itself so that it can be further protected from infection. And once this is sufficiently healed, sometimes the scars are minimally apparent, and a patient may have some difficulty looking at their knee and figuring out which knee has undergone surgery as they continue to heal about a year out from their procedure. The postoperative recovery and therapy programs have really led to some significant advancements in patient expectations as well as performance after surgery. The use of the RomTech device is a pedal machine that's coupled to a monitor that's brought to the patient in their home before surgery so they can see how to use it. Then once they get home, they participate in using the RomTech several times a day. And this is really important as this allows the patient to engage in a home-based therapy program with a monitoring and ability to track their performance over successive weeks of participation. And this is contrasted to the conventional approach to therapy where either a therapist might come to the home twice a week or go to an outpatient therapy facility for twice a week. There's a lot of hassle of having to have someone drive you there, wait in the waiting room, and access to PT can be somewhat limited in certain occasions. So this device is at home with the patient for the first 3 weeks. It really goes a long way to augment their therapy participation, improve their pain scores, and really accelerates their recovery. So by the third week, this device will go away, and then the patients can resume more higher level activity with physical therapy if still needed. But at this point, they're ready to get out and drive and be more independent. And we found that this has been a very important aspect in many of our patients' surgical recovery. They've been very satisfied in using this therapy RomTech device, and I think it'll go a long way to further help bring therapy to the patients more directly and more completely. Other technologies such as computer-assisted or navigated surgical technique was developed many years ago and was a neat introduction of technology into the operating room where we were able to couple conventional surgical technique with a monitoring system and a imaging-based analysis of the patient's anatomy to help effect real-time surgical intervention to accomplish the surgical goal of appropriate knee reconstruction and implantation. And while this is a useful technology in certain outliers, we haven't been able to see a dramatic improvement in clinical outcomes compared with conventional techniques as of yet. However, this was an important first step in using this technology to get to subsequent platforms that I think may be more applicable, useful, and helpful. Patient-specific or customized instruments have proven to be very helpful in this regard as well. And this is where a patient will get a preoperative imaging study, either a CT scan or an MRI. And this will allow us to reconstruct the patient's anatomy in a facsimile, as you can see here shown on the left. And then in collaboration with the engineers can effect a surgical plan to really do the surgery before ever going to the operating room. Certain instruments are built that are unique and customized for that patient's anatomy. And you can see a picture there of that custom instrument fitting on the tibia to do the knee replacement cut on the tibial side. And that's designed to uniquely fit that patient. So the use of patient-specific instrumentation has really allowed us to focus on how to customize each of these surgical treatments to help benefit each patient undergoing knee replacement. This is a picture that demonstrates a partial knee replacement done with a patient-specific instrumentation where you can see just on the inside of the knee, the femur and the tibia are resurfaced with just a partial knee component. And this is done with instruments that are made just uniquely for this patient. So this can show you here on the bottom where that white instrument fits over the femur and the tibia like a glove and really allows the surgeon to kind of understand exactly where they're going to be putting their instruments and securing that to the bone and making their appropriate cuts. I thought that with a partial knee replacement system, this may be more favorable than a total knee replacement system for several reasons, that it preserves more of the normal anatomy and therefore providing more normal knee kinematics. Partial knee replacement, we think, has less morbidity and a faster recovery. And with this custom Oxford implant, we've seen excellent results maintained for up to 15 years in over 85% of the patients. I spent a couple months in Oxford in my training and worked with the surgeons and the team that helped develop this system. And it really has gone a long way to provide a partial knee arthroplasty system, which has proven to be very beneficial for a lot of patients with this particular disorder. In using the patient-specific instrumentation, you can use also a total knee replacement system as well. And this demonstrates that platform being deployed here, where both the medial and the lateral side of the knee are being resurfaced, and a preoperative session, design how best to customize the surgical treatment for that particular patient in terms of where the resection would need to be placed, where the implants will need to be positioned, and how that can further optimize the patient's outcome. So as we stated, there is some preoperative imaging, which will be involved with either a CT or an MRI. That's used to build the patient-specific implants, which can take several weeks to construct. Again, the surgeon will collaborate with the engineers to build those instruments and design the appropriate surgical plan. And overall, we think that this provides additional benefits. This, of course, comes with additional cost as well. And we're still working with different studies that are ongoing to look at whether or not the benefits are worth the cost. But we think that as a proposed benefit, this should help reduce pain, reduce blood loss, and improve alignment, and hopefully satisfaction and survivorship over time with these select patients. Robotic-assisted knee surgery for knee replacement has been around for nearly 2 decades and is not exactly a new technology anymore. It was really the first step of using the robotic system in the operating room, similar to navigation as mentioned previously. And while this was an important first step, I think we've seen that there are some shortcomings of this early iteration of technology, where it's a bulky device inside the OR, can be a bit cumbersome. You can see the arm on that lower picture there displacing some of the operating room team there in order to get the device accurately inside the knee to obtain the data registration that's important to see where that resection would need to be performed and where the components would need to be placed. And while this is a very interesting technology, the literature and evidence thus far would show there's no real substantial benefit in the clinical outcomes when compared to conventional technique. And similar to navigation, I think that robotic surgery may help in some of the outliers or unique deformities or unique custom cases where this type of technology can provide some additional benefit for that additional cost. In the future, there are other platforms that are currently underway and in development using augmented reality, where this is really going to be navigation and robotic surgery 2.0, and then combined with enhanced software and artificial intelligence capabilities. We'll really be able to put a device on the surgeon itself as kind of an enhanced ocular eyewear set that can register the data intraoperatively and provide a lot of the data registration and intent for surgical resection and how to put the position of the components in the case can be done through the augmented reality platform. And so this is really exciting to kind of work with some of these newer technologies that I think will be less bulky and hopefully as equally reliable as earlier technology and perhaps a lot more cost effective as well. So Ortho Carolina is excited to work with new platforms and to see how we can continually improve upon existing technique. And this is one of the features that we're looking at currently. This is still relatively early in development and not currently widespread, but in the years to come, this may be something we'll see more often. So in summary, to go over some of the innovations related to knee replacement, thankfully, we know that most patients do quite well with this procedure. Nearly 90% of patients undergoing knee replacement will feel there has been an improvement in pain, function, and quality of life. And a few years ago, a nice publication by Dick Scott looked at 3 main questions. Are you glad you had the procedure? Did it fulfill your expectations? And would you do it again? And 98% of patients in his particular study answered yes to all those questions. In terms of durability, 90% of knee replacements will last at least 10 years, and up to 80% will last nearly 20 years. We do know that an artificial knee may feel different from a normal or a natural knee, but it should feel much improved from the arthritic diseased knee of someone with really severe knee arthritis. There will be constant and continual improvements in the field of knee replacement going forward, and your providers at Ortho Carolina will be continually working with each patient and the industry to develop the best technique and applications we can to offer the best results to our patients. So in conclusion, we'll continue to advocate that every patient is unique and that a patient-specific approach is best. And enjoy March Madness and root for your teams. And thank you for joining us today. Feel free to reference this on YouTube or Facebook or LinkedIn, and we'll be happy to field any questions if there are any of those at this time. So there's a question here about BMI requirement for knee replacement. So that's a great question. We know that, as we talked a little bit in this presentation, our weight has an impact on our surgical outcomes. And BMI is the metric that we're using currently, which is a combination of a patient's height and weight, which gives us a number. Healthy is usually kind of about 25, overweight's between 25 to 30, and obese is between 30 to 35, and morbidly obese is above that. Patients that have a BMI over 40 have been shown, unfortunately, to have a higher risk for problems or complications, such as wound healing problems, infection, drainage, need for further surgery, malpositioning of implants, blood clots, heart arrhythmias, those kinds of things. So at the end of the day, this is an elective surgery, and we'd love for patients to undergo the procedure and the anesthesia and have a fantastic clinical outcome. And if there's anything that we can do prior to surgery in order to optimize a patient's outcome in terms of reducing weight and enhancing other health considerations, that's usually undertaken because that's a worthwhile endeavor to avoid any adverse outcomes. So another question about holistic treatment, such as castor oil application to the knee. So I think that brings up a really good point. There are probably over 10,000 different types of topical treatments and even oral supplements that have been offered through the years, even in ancient civilization, that have kind of stood the test of time. Castor oil specifically, not sure exactly kind of how that mechanism of it working around the knee, but there may be some way we could look at the literature to see how that would impact someone with knee arthritis. But I think it could be similar to some of the other topical applications, perhaps, but we'd have to kind of see. I'm not familiar with castor oil exactly, but there are many types of different treatments that can be applied to the surface of the knee. And we have some kind of within our regular recommendation for patients with knee arthritis. And sometimes there are other that are outside of that recommendation that patients will come in even share with me or other providers that, I've tried this or I've tried that and found it helpful. And so as long as it's a safe treatment and there's no adverse problem with it, I think that's not an unreasonable thing to think about. At the end of the day, we just want patients to feel better and to do well with things. And if a patient finds that a castor oil application has been helpful, then we'll have to kind of keep that and explore that more in the future. But it looks like that could be a consideration, I think, for somebody maybe. So a patient has had a knee replacement, developed severe arthrofibrosis. And so that's a condition after knee replacement where the knee becomes very stiff, either cannot, straighten fully or bend fully. And that's a problem. We really want to be able to ensure the knee can straighten and bend fully to allow someone to stand and walk and get up and down stairs and out of chairs and cars. So usually arthrofibrosis is followed very closely by the treating surgeon. And about 3 to 6 months after surgery, if it looks like there's a significant limitation in flexion, maybe 90 degrees or less, then there may be some consideration for a manipulation under anesthesia. And that may have some benefit, more so for flexion than for a loss of extension. But it's important to understand perhaps why there's arthrofibrosis, whether it was just an exuberant scar tissue that was formed. Maybe there was a lack of therapy participation for whatever reason. Maybe there's something else that would need to be evaluated more thoroughly to be sure there's not an infection or a fracture or something else that could present and cause stiffness in the knee. So that would deserve a workup and then a possible secondary treatment like a manipulation, maybe a further surgery like a revision, possibly, but it would need to be clearly understood as to what was the cause and the reason for failure there. So the question is, how do you select the manufacturer of the knee replacement hardware? Is a great question. I think it's kind of like cars that there's probably at least 20 different types of car manufacturers available to people driving in the U.S. There's probably at least that many types of knee replacement devices in the U.S. as well for surgeons to kind of work with. Usually, a surgeon will have a familiarity with a certain system, just like there are certain people that are Ford drivers or Chevy drivers or BMW or Mercedes. There's certain surgeons that are very comfortable with the instrumentation and have worked with the system and kind of know how it works in their hands and have seen their patients for follow-up to ensure that the systems provide good results. And so at the end of the day, there are many types of knee replacement systems. All of them that are being used in the United States have been through a very rigorous process and vetted by the FDA. And it's important just to have a comment with the surgeon that you're working with to ensure that they've had some good experiences with it, and if they've had any other experiences with other knee replacement manufacturers, if that's an important question for the patient to have answered. So, a question about a patella tendon rupture repair done 30 years ago, and now there's some bone-on-bone arthritis in the knee, I expect, is what we're hearing. So this could be a little bit more complicated of a knee replacement case, simply because the patella tendon is an important link in the extensor mechanism of the knee. So when someone's trying to straighten up their leg, that patella tendon is important to be able to allow the knee to straighten. And if it's been injured and then repaired, there's probably some scar tissue that's formed in that area. It may lack a certain elasticity that we normally see in uninjured tissues. So this could be technically a more challenging surgery in terms of exposure of the diseased knee joint and access to the knee joint to safely perform the procedure. That could be a little higher risk for a problem like a recurrent tendon injury, but doesn't preclude knee replacement. It just needs to be done technically very carefully to ensure that that can be done properly, and just would be a little higher risk associated with it. Again, having a prior knee surgery before knee replacement does also bring in a little higher risk of infection and postoperative arthrofibrosis or stiffness, like we heard from the previous question. So just having that awareness going into the considerations of knee replacement are important to kind of really understand and have all the expectations kind of laid out before surgery is undertaken. The sciatica, common occurrence after knee replacement surgery. So not particularly common, but I think most patients that have arthritic disease in their knee that's rather advanced usually have some other musculoskeletal disease, and that may be in the lower back and the lumbar spine particularly. And if someone's altering how they're walking because their knee is inflamed and sore, then they may not be walking with a reciprocal pattern, and that may put more pressure on the lower back. If they're recovering from surgery, that same scenario may be present. And if there's some underlying lumbar spine disease, that may aggravate a condition and lead to sciatica. So that can happen. You can see kind of where that would be possible. I don't think it's a particularly common problem, but I think a lot of us that have done a lot of knee replacements have seen that develop in a few patients. That needs to be treated just like it would any other time sciatica would arise, and just with resting, perhaps a muscle relaxant, massage, some other kind of non-operative treatments can be helpful in that case, if that would be helpful. So if I had a hip replacement in May and would likely need a left knee replacement as well, how soon after my hip replacement should I consider to have a knee replacement? Very good question about, timing of multiple successive surgeries. And I think, getting back to some of the questions about BMI and trying to reduce a patient's risk for adverse events comes down to multiple surgeries being considered in the same year as well. Typically, we would advise patients to wait at least 3 months from one knee surgery to a hip surgery, or from a hip surgery to a knee surgery, just with the thought that your body physiologically needs to recover or recuperate in terms of getting your blood counts back up, getting some of those inflammatory markers that are in the body after surgery back to their native and normal levels, to help kind of reduce the discomfort that may come from a surgery, to be sure that the patient can have the best outcome and that their therapy and postoperative rehab will not be impacted by another surgery from earlier too. So being sure that they're doing quite well from their initial procedure and ready to proceed with the second procedure will be important. About 3 months is typically what we would advise patients, as long as they're doing well from the first procedure. Is it true that too many cortisone shots is damaging the jaw? So I think there is some thought that multiple cortisone shots, you do change the microenvironment inside the knee joint, may have it a little more acidic, perhaps, and that may lead to some denaturing of the cartilage there and accelerate some of the demise. I'm not sure that's borne out in the evidence. It's more probably a conjecture at this point. But after it's demonstrated that a cortisone shot isn't very beneficial, there's probably no more need to continue doing that type of injection. I think it's not a bad idea to alternate a cortisone and a gel injection just to see which type of injection could be beneficial. And even think about possibly PRP as an option as well in patients with mild to moderate arthritis. I think some of the literature and evidence has shown that PRP probably has a longer duration of impact in terms of positive result for patients with mild to moderate knee arthritis when compared with cortisone and HA injections. What are your thoughts on osteochondral allograft transplants? I have bone on bone and I've been told no knee replacements until March. So great question. Cartilage damage is a difficult problem to deal with, both medically and surgically, as well as other non-operative treatments. Depending on age, I think osteochondral allograft can be an option. I think we have several experienced surgeons at Ortho Carolina that do a lot of osteochondral allografts. And if a candidate is considering that, or if a person would be a potential candidate for that procedure, we would have that particular patient consult with one of our Ortho Carolina docs that does the OATS or osteochondral allografts, and kind of see if that's an option. I know that just from my experience in training, that patients' age has an impact on certain things, as well as the size of the defect and the particular location of the defect. And depending on those considerations, that may have some impact on the anticipated outcome with a osteochondral procedure. Knee replacements, while effective for advanced knee arthritis, are not a perfect solution for everybody. And someone under the age of 30 is probably not an ideal candidate, just for the thought that they're going to be more active, as well as that implant has a survivorship that's defined. It may be 10 to 15 years in someone that young, with the thought that a subsequent revision surgery might be needed. So depending on the age of that particular patient, whether an osteochondral surgery or a knee replacement surgery would be considered as part of what that discussion with your Ortho Carolina knee specialist will include, and bringing it up to kind of be sure that all your options are explored will be a part of that consideration. So next question's about left knee pain, lower back pain. Is one causing the other to become worse? Yeah, I think it's an important question to understand, because a lot of us will have different aches and pains at different times in our life, and rarely does one joint kind of operate in a vacuum. Where the old nursery rhyme with the knee bone connected to the hip bone connected to the backbone is appropriate, because we alter our movement and gait and mobility based on pain and injury and those types of things. Whether or not the back is actually causing the knee problem is probably not exactly the case, but it's causing some altered movement, and that may facilitate some higher stresses across the knee that may aggravate an underlying knee problem. So that may be a part of it, and together they need to be managed in order to kind of help address both issues, provide sufficient and satisfactory treatment. So I'll be a part of just working with your Ortho Carolina doctors to help address those particular problems, to see if any other imaging or diagnostic studies would be helpful to figure out how to treat that appropriately. So the next question is, what is my opinion on cold laser therapy and laser 4 therapy to assist in healing as an option before surgery and help repair injured tendons? And so I think that's a very good question. We're starting to see more photo-based treatments, whether it's cold laser or different types of lasers, having some impact. And I've had a few patients that have looked at this particular treatment and swear by it and think it's very helpful. I don't know if we have the quality of level 1 research and evidence yet to say that these are better than other types of medications or injections or treatments that are offered for knee arthritis. So I think this should be an active area of research going forward to see, if it is helppful, why is it helpful, so we can understand that. And that will further allow us to manage knee arthritis in patients with this condition. So I think it's being offered, across a lot of different places. Sometimes the challenge is that it's not covered by insurance because there isn't a whole supportive level of evidence to advocate for it. So hopefully that'll be something we can see turst out in the future. But I know some patients have deployed this technique and found it helpful. It's just hard sometimes getting it covered by their insurance plans. They may have to cover it with out-of-pocket coverage, and that would be up to the patients to decide. Next question is, what is the solution if you have a long leg syndrome from the previous knee replacement? So it sounds like this may be someone either has an apparent or a true leg length discrepancy. It may be, I guess, associated with an underlying condition or a prior surgery. It's sometimes hard to know exactly from this particular question, but it'd be important to understand, why is there perception of long leg, whether it's a pre-existing deformity or it's following a surgical treatment, kind of what would be kind of the necessary next steps to manage that, whether it would be focusing at the level of the knee or somewhere else to kind of help address that problem appropriately. So I think that would be working with your knee specialist and having a full length x-ray to kind of examine exactly where that leg length discrepancy is noted and how to best address that would be probably an appropriate discussion with your Ortho Carolina specialist. PRP versus laser 4 therapy, best outcome. So that's a great study that would need to be done. We don't really have any evidence yet. These are some good questions looking at some next level of treatments that just don't have the data out there at multi-centers in terms of being blinded and randomized and controlled in ways that we can use that to help support further advocacy of both PRP and laser 4 therapy. Here at Ortho Carolina, we are actively involved in research and put out many publications every year as a part of this effort to look at these newer types of treatments and really see if they are valid, and if so, how, and then what is the value of using them in treatment of patients with these conditions. So we are now enrolling patients in a study that'll be looking at PRP as it compares to steroid and HA injections. So look forward to that coming forward. I think whether or not the laser 4 therapy has a role in that particular patient with knee arthritis is a good question. Will need to be kind of asked at the scientific level, and hopefully Ortho Carolina and some other organizations out there can continue to do research and provide answers about the possible incorporation of that going forward. So a question about tired of being in pain. Is this the way of life and expectation that comes with arthritis in the knees? And so I think this is a great question, kind of designed for what, hopefully this webinar can, help someone understand that, their arthritis pain is derived by a disease that's the cartilage is worn away and causing a lot of this. And so working with your Ortho Carolina knee doctors, understanding, exactly kind of why this is the case. And then, some of the options that we've shared here today should be something that you can look forward to trying to see whether or not from a non-operative aspect that could be helpful. And if that is not successful, then, as we tried to share here, that about 90% of patients will note a good improvement with knee replacement in terms of pain relief, quality of life, and function. So work with your Ortho Carolina knee doctors and explain kind of your perception of the pain, and hopefully there's some treatment options that would be available. And if not, then maybe surgery would be the next step, and just having that discussion might be helpful for this particular person. I have a small meniscus tear in the left knee due to a fall. Looks like physical therapy was completed. Will it heal on its own or only by surgery? I work out regularly, lifting weights, and I'm scared to work out now. So very good question. I think when we have some structural damage inside our knees, whether it's a meniscus tear or it's arthritis, it manifests as pain and dysfunction. And so I think we need to alter our activities to avoid the real vigorous impact, cutting, twisting type activities, because you could take a small meniscus tear and make it into a very big meniscus tear that would likely require surgery. Small meniscus tears may not require surgery. Usually it's not so much that there is a tear, it's usually associated with some type of mechanical disruption. So if it's popping, clicking, or locking, or causing some inability for the knee to straighten or bend properly, or for the knee to function appropriately, is when someone would think about undergoing a joint preservation or knee arthroscopy type of procedure, where that can be done as an outpatient, where the small meniscus tear could either be repaired or removed. And that would be an appropriate way to treat that if it didn't respond to the non-operative measures. Will stem cell surgery help the days, and will Medicare pay for that? Good question. I think that stem cell surgery has a lot of hope attached to it, as it's a form of harvesting these types of cells that are very special, that haven't moved very far down their lineage of division, so they can become bone cells and cartilage cells and healing cells, immune cells, and whatnot. And so I think there's a lot of effort in the biomedical sciences to understand how best to identify those cells and harvest them, and then engineer or direct them in a way that can make them a deployable technology, perhaps combined with some form of nanotechnology. We can harvest stem cells and then direct them into a knee that has arthritis, and have some successful regenerative options there. We just haven't realized that yet in 2024, and that's and obviously an area of interest by a lot of industry. And Medicare will not pay for that as of yet. Neither will probably any of the private payer insurance companies, as usually those payer systems will require certain years of evidence and proven clinical data before they include that in their types of services they will cover. So stem cells aren't typically covered as of yet for knee arthritis. So hopefully that will provide a good overview of knee arthritis and different treatment innovations that can be considered. And hopefully you found value in that demonstration today. Thank you for joining us. And we'll happily post this on YouTube and LinkedIn and Facebook. And feel free to review this at a later date and submit your comments so we can continue to make this a good interactive experience for everybody involved. Have a great day, and thank you for choosing Ortho Carolina.